I am really delighted to introduce my colleague and friend, Kate Mawhinney, who runs the Elder Law Clinic at Wake Forest University at our School of Law. And Kate has been an active participant in our Aging Reimagined Symposium planning from the first year. So, Kate, we're delighted you're here, and we're delighted that you were able to share Charlie with us. So thank you.
Thank you, Christina. How's everybody doing? Are you pumped up? Yeah, that was such fun. I'm going to go get myself a drum. All right, so we have the good fortune of having Charles P. Sabatino here from Washington, D.C. He is the director of the American Bar Association Commission on Law and Aging. So when lawyers in our country have issues in their representation of older adults, they call him. He has been the president of the National Academy of Elder Law Attorneys, which has 5,000 members, and has taken a position on a lot of policy issues that we've heard about up to now. So when I heard about from Sam Matthews, income security in retirement, I think about, as a lawyer, ERISA and the laws that protect our pensions. When I heard from Dan about his caregiving struggle, I think about the rights of caregivers and what are the laws that allow people to leave and take care of their loved one, or do we need more laws that would allow them to do that? When I think about long-term care and the many, many people who come to us and ask us, how will I pay for this? What property will I lose? What should I do? I wanted to leave something to my family. I think about our laws on long-term care policy. So in the arena of policy making, recommendations about the law, the American Bar Association Commission on Law and Aging is really the leadership organization. So we're tremendously lucky to have him here. Now, that is Charles P. Sabatino. Now I'm going to talk to you about Charlie Sabatino. Charlie Sabatino has more important titles than director of the ABA Commission. He is known in his son and daughter-in-law's house as Grandpa. And he's known at his daughter and son-in-law's house as, recently, a month ago, the father of the bride. So there's a lot going on in Charlie Sabatino's life. I think he's proudest of his recent role as father of the bride. And we're just tremendously lucky to have him here. So please welcome Charlie Sabatino.
I actually figured you'd be wondering why, after that wonderful exercise of music, this guy's going to stand up and talk about AIDS and death. Is this crazy or what? Well, most of this is really much more upbeat. It's all about living until the end. And that actually should say AIDS and dying, as the term goes, but so be it. I do have the clicker. Okay. What do I mean by aid in living? Well, it's actually a term I made up. It's not a technical term that's out there. But I borrow the definition, which is the vision of the Coalition to Transform Advanced Care, which is a large coalition of some 140 groups of providers, consumers, insurers, regulators, a whole variety of groups that I have the pleasure of being involved in as a founding board member. I'm not part of their board anymore. But I still very much support their work. What they focus on is this vision. All Americans living with advanced illness, especially the sickest and most vulnerable, will receive high-quality, person- and family-centered care that aligns with their values and goals and honors their dignity. That's the vision we're going with. Now, where does it fit in the continuum of care? Advanced care is that second bubble from the right. It is more upstream than hospice. It addresses advanced illness, and advanced illness is defined by the coalition this way. It occurs when one or more conditions become serious enough that general health and functioning decline, curative treatment begins to lose its effect, and quality of life increasingly becomes the focus of care, a process that continues to the end of life. So actually, conceptually, advanced care should also include hospice, but it doesn't technically include hospice today because the hospice benefit under Medicare requires you to give up all curative care in order to get the hospice benefit. So that's the concept of advanced illness. Where are we today in meeting that vision? Well, we actually have a long way to go. You probably can't see all the typing on this, so I'll just tell you what it says. You already heard a lot about the changing demographics. Also, the majority of us will suffer a period, probably in years, of chronic illness and differing levels of dependency before death. Because of that, there's a growing need for specialized care characterized by high needs that really call for a blend of social and clinical or medical resources. We are facing a shortage of available caregivers, which means that we have to that the primary means of caregiving in our country today is family caregiving. Payment reform has been underway constantly for years now, moving away under Medicare from a fee-for-service model to what has been partly a capitated model, and now for a value-based care payment model, the definition of which is not quite clear, but a big focus of payment reform today. But still, the common vision behind all these changes is it's intended to be person-centered care, matching a person's values and goals of care. So this model of advanced care, I mean, some people ask, well, isn't it just palliative care? Well, palliative care is a key part of it. It's a specialized form of medical care that focuses on relieving pain and symptoms and addressing the physical, psychosocial, and spiritual needs of individuals. Very important key element of advanced care. But advanced care is a much more systemic concept that includes these elements: personal care planning, consumer and family caregiver education, information and support, quality standards, professional education, payment mechanisms, health information technology. I should also put a seventh one up there of research, but I'm not going to cover research today, so footnote that one. Let's go through each of these very briefly. Personal care planning. We know that too few people use advanced directives today. These bars represent from a study of 150 articles published between 2011 and 2016. Oops, I didn't. Excuse me for that. I'm looking at two different screens here, so I have to keep them in sync. And we find that during that period of time, about a third of Americans do advanced directives, and it hasn't really changed that much over time. Now, what this doesn't show is that there is an age relationship. The older the person is, the more likely they are to do an advanced directive. But one of our main mantras has always been advanced planning is just as important for the 20-something as it is for the 60-something. Why aren't more people doing advanced directives or advanced care planning, as I like to focus it on? Well, they find that the forms are often hard to understand. Most states have adopted forms right in their legislation, written, of course, by lawyers, and they're usually at the 12th grade or sometimes even higher level of reading. The standard forms, clinicians tell us, don't provide all that much guidance. They usually have checkoffs of wishes about certain kinds of treatment. We know that people change their minds, and as Ashton Applewhite said yesterday, quoting the Spanish proverb, the bull looks different from inside the ring. Well, once you're in the ring, especially when you're looking the bull in the eyes, your priorities change. And the empirical research has shown that about half the people will change their mind during a course of serious illness about what their priorities and goals of care are. We know that agents or proxies under healthcare powers of attorney are often uninformed, and we really have not had that conversation with the principal who created the document, and they really don't know what the job description of an agent is. Healthcare providers are often clueless as to whether an advance directive exists. It seldom gets in the record, or doesn't get in the record often enough, and even if it is in the medical record, it's often still lost in space because nobody quite knows where it is. Now, the most important report on this topic in the last decade has been the Institute of Medicine's report. They're now called the National Academy of Medicine, but I'll still refer to them as the Institute of Medicine. It's my habit now. They wrote Dying in America, published in 2015. And of their many conclusions and recommendations, there are three I'm highlighting here. Many people nearing end of life can't make their own decisions. Most people, given adequate information about their condition and options, would choose caring over curing. However, the default is the opposite. They get curing over caring. Frequent clinician-patient conversations about end-of-life care, values, goals, preferences really do help avoid unwanted treatment and align it with what the patients want, but they don't happen nearly enough. The Institute of Medicine also spelled out a vision of advanced care planning that refers to the whole process of discussion of end-of-life care, clarification of related values and goals, and embodiment of preferences through written documents and medical orders. And they focused on the process being one of, essentially, the important part of it, one of reflection, discussion, communication, and the written documents, particularly advanced directives, were a part of that, but a relatively small part of it, as this Venn diagram shows, of the smaller circle within the larger circle. But traditionally, over the decades, people have thought of it just the opposite, as oh, advanced care planning means I do the document, and there's a little bit of discussion in there along the way. It should be just the opposite, as this chart shows. The report of the Institute of Medicine also talked about the lifetime process of advanced care planning and how it changes over time. For a healthy person, a younger 20-something, they're not really inclined developmentally to be thinking of death and dying issues, but they certainly can think about the need to have a proxy decision maker if they were in an accident and temporarily needed somebody to make decisions for them. As one gets older and experiences different medical conditions, chronic conditions, and experiences deaths of family or friends, they have different goals of care. They may be looking at long-term management of chronic care. They have developed some values and priorities in life that they would express in an advanced directive. As they near the end of life and they're now in the ring looking at that bull, their wishes become much more specific about specific treatments, and this is where the relatively new instrument of medical orders for scope of treatment, as it's called in North Carolina, comes in. It's more generally called, and excuse me if I keep calling it PULSE, because the first state that adopted it, Oregon, used that name, Physician Orders for Life-Sustaining Treatment. So PULSE, MOST, whatever acronym you hear me bellowing, that's what I'm talking about. One of the things that is actually encouraging, but it's frustratingly slow, is a change of models of advanced care planning. It started out in the 1970s with the passage of the first advanced directive laws, living will laws and healthcare power laws, as really a legal transactional model. And this is probably too small a print, but the box on the left gives you some of the traits of the legal transactional model. It focuses on mandatory legal formalities and procedures, standardized legal forms. The forms focus on checklist options for treatments. There's a big focus on execution, having the right witnessing of the documents. And the carrot in these laws were all immunity for providers to get them to go along with what patients said they wanted, which was an unusual thing in the 1970s, and it's still unusual in many cases, but has become more and more the standard of care. And that model has moved away, at least in the clinical world, towards a communication approach. The communication approach, less focus on forms, more discussion focused around goals and values, less on specific treatments until you're at the point where you're facing specific treatments. The legal focus is really on appointing the proxy. You know, naming someone to be your legal proxy or agent is really was created by statute. It didn't really exist in the common law for people to be able to name you as an agent even while you lacked capacity. So it was a creature of statute. That's really the only legal task. The rest of it is all communication. And lawyers and advanced directives don't have a monopoly on communication, and sometimes get in the way of good communication. And this communication approach is developmental in nature over time. And in advanced illness, the trend is to focus on converting wishes into a set of medical orders, which is represented by POLST or MOLST. Oh, where'd my clicker go? So in the area of advanced care planning, there are many promising signs of change. I want to point out a few of them. For one, we have seen a growing number of advanced care planning tools that help one reflect upon and have a guided discussion with family or physician, friends, and eventually develop that into a plan that can be put into an advanced directive. And I list a bunch of them here. I'll just name a couple of them. The first one is prepareforyourcare.org, created by a physician at UCSF. That is a very robust web page with educational short videos, testimonials from people talking about how they thought about this, and it walks you through several steps of naming an agent, naming or specifying priorities, how to talk to others, and eventually coming up with a plan that you could then, either get your state's advanced directive and customize it according to your plan, or have an attorney do for you. The Conversation Project, which is the third bullet there, has become very well known. It has a set of talking tools that are very simple to follow. And we are really encouraging this kind of direction of giving people some tools, because it's really hard to say, oh, you ought to have a conversation with your family members. Well, how do you have that conversation? How do you even think about it? And that's what these tools are really getting, and I think that's a very positive sign. Other positive signs of change. In 2016, CMS, the entity that regulates Medicare and Medicaid, authorized reimbursement for advanced care planning discussions with physicians. I'm sure most of you know that now. That was a very big step forward. We are seeing more and more instances of cases really affirming and reaffirming the right of patients to express their wishes and to have them followed. I just named one here, California recent case, but we're seeing that recognition more evenly expressed. And POLST, which began really back in the early 90s in Oregon, in 2004, when the National POLST Task Force was created, there were only 6 states that had POLST operating throughout the state. Now, virtually every state has POLST or MOLST in some stage of development, and 23 of them have, quote, endorsed programs, which are programs that meet the standards of this, the voluntary standards of this national task force on POLST. So that has grown dramatically. Just a word about POLST. The idea of it is that even though we have done a lot to encourage people to think about these issues, to communicate them with family, to document them, on the left side, on the left cliff, is the family at the bedside who have done all that. They think everything's been clear. The family members know what mom or dad wants. And now dad is in the hospital. Well, how does all that get actually translated into the actual care that dad gets in the hospital? One of the problems with advanced directives is they don't really speak the language of healthcare systems. Healthcare systems operate on what? Think about it. They operate on medical orders that are in the chart and on standard medical protocols. So the trick is to get all that discussion that the families had and whatever they've documented kind of into that mechanism that drives care. And that's what POLST or MOLST is supposed to do. It's an additional systemic step to bridge the gap between a patient's goals and preferences and implementation of an actual plan of care in the here and now. Particularly and this is specifically for patients facing advanced illness, because these are the patients looking the bull in the eyes, where there are high probability critical care decisions that will have to be made about whether to hospitalize, whether to use resuscitation, whether artificial nutrition and hydration. And so POLST or MOLST helps translate one's wishes into that plan of care and it requires a discussion and shared decision-making with the family, and physician, and surrogate. So it requires that discussion, requires that translational effort by the medical professionals. It must follow the patient across settings, and this is one of the most radically difficult things to do in our country, but that is a part of MOLST, and it requires regular review. You don't do POLST once and then, that's it. It really needs to be reviewed whenever the individual's venue of care changes, whenever their condition changes, or whenever they express a change of wishes. Okay, let me turn to caregiver support issues. Excuse me, I've got myself out of place here. Here we go. We know that there's a growing gap for the demand and supply of caregiving. At any one time, the Institute of Medicine, in a recent report on family caregiving, said almost 18 million individuals are family caregivers at any one time. However, if you look at a year's period or even 5 years period, that number doubles and then triples, and it is all primarily family members. Caregiver role has become far more complex and demanding than it ever has been before. Helping family members with tasks that used to be skilled medical interventions is becoming the norm, and it's particularly difficult with family members, as you've heard, with dementia and Alzheimer's disease, which pose all sorts of difficult challenges to us. We know that more than half of family caregivers are employed, and they face a particularly high risk of financial harm because of that position. Many have to reduce work hours. Some are victims of what we sometimes call family responsibilities discrimination. People think because you've got to take time off to take care of family members that you're not really as concerned about your work as other employees. And it's a bias that more and more people are experiencing. And there are systemic barriers that prevent family caregivers from effectively engaging in care. Very often, healthcare providers, even though the family caregiver is going to be the key caregiver, they're kind of excluded from the planning team, from the treatment team, from discussions. They aren't really identified as the family caregiver, and at discharge, they aren't really given the tools that they need to know what to do when they get home. There are also great economic disparities. This slide shows you some statistics from the Bureau of Labor Statistics that tells us, looking at people who are employed who have any kind of paid leave, whether it's vacation leave, sick leave, personal leave, or family and medical leave, any kind of leave. The lowest 25%, the lowest quartile of employees, 44% of them have no leave of any sort whatsoever. In the highest quartile, only 5% have no paid leave whatsoever. So huge economic disparities in family caregiving. But there are some positive signs, not as many as I'd like to see, but there are positive signs. The federal government passed in January of this year the Federal Raise Family Caregivers Act. Now, this is an example of how federal legislators love to come up with these long acronyms to say something that stands for Recognize, Assist, Include, Support, and Engage Family Caregivers Act. It directs Health and Human Services to develop a national family caregiving strategy, much like they developed a Alzheimer's disease strategy, national strategy. And it calls for the convening of a family caregiving advisory task force to advise government in recognizing and supporting caregivers. At the state level, we've seen a fair amount of legislation. In 2015 alone, 31 states passed 40 bills to support family caregivers. The most common one was the Caregiver, another acronym, Caregiver Advise, Record, Enable Act, or the CARE Act. And that act requires providers to identify who the caregiver is and ensure that they are a part of discharge planning and given the training and the tools that they need to provide care after discharge. Now, we haven't had much experience with the implementation of any of these yet, so we really don't know how big of an impact they have. Okay, let's move to that third component, quality standards. In the last decade, the triple aim has been what seems to be guiding all the thinking and talking and action on quality standards. The triple aim, as defined by the Agency for Healthcare Research and Quality, is one, better care, healthy people and healthy communities. I guess the Y is missing from that word. Healthy people, healthy communities, and 3, affordable care. So most standards have been kind of framed and evaluated within that kind of framework. And the body that is most active in this area is the National Quality Forum, which is an independent entity created by Congress, which, let me see, which looks at proposed standards that are out there, determines whether there's enough of an empirical base to endorse them, and if there is and they're approved, then CMS has to give them a greater deference than any other standards. And they've developed partial standards to varying degrees on shared decision-making, palliative and end-of-life care, care coordination, and a number of things. But we really have, on the one hand, a profusion of standards. People can't even count how many there are now, and it's very confusing. At the same time, there are many that really don't get to the nub of quality, particularly when you look at things like advanced care planning, which really depend upon the quality of the conversation. And having a standard that, you can count how many advanced directives there are, which is a very superficial standard, but you can't really, we don't really have the tools right now to easily evaluate the quality of those conversations. CTAC, the coalition, has come up with an index on advanced care in which they try to evaluate 5 domains: the quality and timeliness of care, caregiver support, community support, cost-effective care that's aligned with the individual's goals and values, and compassionate, coordinated communications. It's actually a very crude measure right now, but they're trying to come up with a way of evaluating the progress towards that vision of quality advanced illness care. Okay, professional education. Let's talk about that for just a minute. The Institute of Medicine Dying in America report, among their findings, it included these: that hospice and palliative care are generally absent from the usual curricula of medical and nursing schools. Now, we're seeing that change, but when you look at the country as a whole, we're not far enough along the road to ensuring that. 2, persistence of single profession education silos, which are antithetical to interdisciplinary team-based care. The bar for advanced illness care is just that, interdisciplinary team-based care. And 3rd, the lack of attention to developing clinicians' ability to talk effectively to patients. Now, we're also seeing lots of medical schools making this a regular part of the curriculum, which is very important. And I think that's a good sign. A particularly good sign that I noticed recently was that, as far as I know, Oregon Health Sciences University is the first university to make that a condition, passing a competency assessment in communication as a condition of graduation. And they use actors, and they use a team of assessors, and it's a very thorough process. So that is a good sign, I think, in the right direction. Okay, payment mechanisms. What I want to do here is actually skip ahead a couple slides. CTAC has created an advanced care model, and most of the examples I'm going to give you are some variation of this model. And what this model looks like is this. It usually focuses on patients who are Medicare fee-for-service patients with advancing chronic illnesses. And the delivery components will generally involve concurrent, curative, and palliative care, which is something we can't do under hospice right now. It includes care coordination across providers and settings, very hard to do in our health systems. It includes comprehensive advanced care planning as a key element. It involves shared decision-making with the patient, the family, and providers, and 24/7 access to clinical support. This is very much home-based, focused care. The payment models have had variations. They've generally involved some kind of capitated model of per member per month. They may involve, when the federal monies are involved, a shared savings or shared risk component. And they also focus on, as I said, ensuring that there is adequate home-based care, with primary care being the front runner, and the needed specialists as needed. So going back to some of these models that have proved exceptionally well, and I'm just naming a few of them. Cambia Health Solutions use a version of this advanced care model with a large number of their members, 94% satisfaction rate from it, and hospital readmission rates were reduced from 30% to 25%. That's significant but modest. Kaiser Permanente, a 33% reduction in total medical expenditures, 55% reduction in the average cost per day, and more than 2 times greater likelihood of dying at home, which is the preference of most patients. Sutter Health, a Northern California group, their advanced illness management program, in an evaluation of 90 days pre and post intervention, over a 59% reduction in hospitalizations and a 67% reduction in ICU days, and over 95% physician and patient satisfaction. You don't get many programs with that high satisfaction rate. And Aetna's compassionate care program, their program actually focused on non-Medicare patients because they couldn't get approval to do it, but they had similar results, an 82% reduction in acute inpatient days, 77% reduction in emergency room visits, 86% reduction in intensive care, and considerable, all these programs had considerable cost savings because of that. And Randy Krakauer, the physician who headed this program, has said, I've heard him speak on this on a couple of occasions, that in the 5 years he was head of the program, he never got one complaint about it. He said he's never done anything. You can't give out $100 bills to patients without somebody complaining about it. And he never got a complaint about this program, so he was absolutely astounded by that. So that's some of the creative things going on in advanced care models that we hope to become the norm of care someday. And on the federal side, legislative side, there have been some positive things going on too. Just about a month ago, the passage of the Chronic Care Act, which is another tour de force in acronym making, stands for Creating High-Quality Results and Outcomes Necessary to Improve Chronic Care Act. It requires a GAO study of comprehensive care planning services, of the impact that they would have. It extended a program called the Independence at Home program for a couple more years, which is a home-based primary care coordination program that CMS's own results show that it has produced a high level of satisfaction, a lower hospital admission rate, and tremendous savings. The Act also provides for new options for Medicare Advantage plans to provide services that wouldn't normally be covered by Medicare, such things as coordinated care planning, even in-home aids could be theoretically included under it. We won't really know how much flexibility CMS will provide until they come out with regulations. But that's like opening the doors to Medicare to a whole range of long-term care services. On the case law side, an interesting case that I want to highlight, it was called Jimbo versus Sebelius. It was settled, it was a suit against CMS, settled in 2013, but CMS really dragged its feet on doing anything about it. It was a case that challenged the Medicare rule that said you could get skilled therapy as long as there was some improvement or progress in your functioning from the therapy. Now, the statute has never said that that was the limitation on skilled therapy, so that's why they were sued. CMS agreed that the real standard was that if skilled therapy prevented or slowed decline, then it could be appropriate to maintain function or to prevent or slow decline. Improvement or progress was not needed to be shown in order to get skilled therapy such as occupational therapy, physical therapy under Medicare. CMS, they had to go back to court last year, and CMS has finally come out with a very clear set of guidelines that is on their webpage. But you know, they're announcing it and actually getting into practice, there's always a lag time. So it's important to know that theoretically a person who needs skilled physical therapy in order to maintain or slow the decline of their function should be able to get that for as long as they need it. Isn't that radical under Medicare? And finally, there is a demonstration program going on called Medicare Choices, which would allow Medicare beneficiaries who elect to receive the hospice benefit not to have to give up the curative care option, which they have to do now. The demonstration was originally set to use 30 Medicare certified hospice participants, but there was such a huge demand that they expanded it to 140, which have all been identified and are participating now. The project is a 5-year duration, so we won't hear results for a while. But this is a radical departure from the traditional Medicare model. And finally, some legislation to watch. This bill has been in the last couple Congresses, the Palliative Care and Hospice Education and Training Act, which would provide a huge infusion of training and resources for healthcare professionals on palliative care and hospice education. On the House side, it has 265 co-sponsors. So it needs a push to get over the hurdle. On the Senate side, 29 co-sponsors. The Patient Choice and Quality of Care Act is an act that would create a care planning and coordination benefit within Medicare, and it would also authorize a huge demonstration in this advanced care model that CTEC has been promoting. That doesn't have as many co-sponsors, but it is it has some traction that could make it possible. But you know, in our political time right now, we've gotten some surprising legislation through in this past year, even despite the political climate that we're in. And finally, health information and technologies. That should actually be number 6, not number 7. But this is an area where, again, the Dying in America report found that the federal standards that had been out there, called meaningful use standards, did not require, in the major commercial electronic health records systems, did not provide for a very robust documentation of advanced care planning, including advanced directives. Some systems have taken it on to do it themselves quite well, but the majority have not. What we want to see eventually, and you probably can't see this, but this is supposed to be the picture of the top tab of an electronic health record. The menu tab, where you have tabs that are always on your screen, shows over on the right-hand side, it says Advanced Care Planning. This would be a one-click way of getting to any advanced care planning documentation, whether it be one's advanced directive, whether it be clinical notes, whether it be MOST or POST. Some health systems have gone that way. Unfortunately, it's not required, and the vendors of electronic healthcare systems would rather have your health system pay them a lot of money to customize their system to do this, instead of providing it as a standardized component of every medical record. In the absence of effective electronic medical records, registries have been promoted. They've been around for many years, actually. About 15 states have created state registries for advanced directives or POST or both. And private registries have been around for a long time, American Living Will Registry, DocuBank, and others. But none of these have ever gotten a critical mass of participants that really made it a functional way of getting quick access to advanced directives. And whether registries eventually take off or whether electronic health records really get a handle on the problem, it's hard to predict. There have been bills to promote registries, or at least study them, and of course there's always the movement towards trying to improve electronic health records. So I can't even guess right now which direction will prevail, or both of them will remain a part of the picture. So back to the vision of advanced illness care. I think the future is one we'll eventually get there too, but we need to accelerate and scale innovations like these advanced care models that have shown tremendous results. We always have to address costs when we're dealing with anything the federal government's involved in or a state government. We need to measure effectiveness better, particularly around advanced care planning, where the quality of the conversation is the key. We need to strengthen policy advocacy, capitalize better on technology, and initiate and grow partnerships, such as CTAC, to achieve all of the above. So that's the vision and the activities around this concept that I'm calling aid in living, living to the highest level of ability till the end. At the same time, a growing area of legislation at the state level and discussion has been aid in dying. And it's a very controversial issue, and it's not a type of legislation that's likely to become very likely in North Carolina, but you can't avoid hearing about it regularly in the news and in national debates about whether it is really a necessity for personal autonomy or whether it's a devaluation of the lives of persons with disabilities. It depends upon whom you talk to. But we now have 6 states plus the District of Columbia who have legislation legalizing physician aid in dying or physician-assisted suicide, whichever you want to call it. The state of Montana is listed on here not because they have legislation, but that they have a case in which their law against assisted suicide was held unconstitutional, and therefore there is nothing to prevent assisted suicide or aid in dying in Montana. So they're on the list. So, and many more states now have, I'm sorry, I don't have the list up there. This is the list which you can't read anyway because it's too small. California, Colorado, DC, Hawaii, Montana, Oregon, Vermont, and Washington. All the states that have adopted legislation on aid in dying have followed this template. For eligibility, they require terminal illness, which has been defined as a likelihood of 6 months or less to live, the ability to make and communicate healthcare decisions, so you have to be competent, the ability to self-administer the prescription drug, which is usually a pill or pills, and the choice must be voluntary. The procedural protections that are included in all these statutes involve making sure the individual is fully informed of their options, the verification of their condition, their terminal condition, by a second physician, and repetition of the request. The first, an oral request, a 15-day waiting period before a second oral request, then a written request to the physician, and then a 48-hour waiting period before you can get the medication. They all include counseling and referral if there are mental health issues identified, and they all have multiple documentation and reporting requirements. So how do we evaluate the wisdom or effectiveness of these kinds of statutes? I mean, there are many aspects to aid in dying, and most of the discussions you hear don't really cover them fully. Or even well partly. And we're not going to cover them all here today either because there isn't the time to do that. It's a long discussion. I'm going to focus mainly on the legal concerns that I have, but one also has to take into account the personal experience of individuals, the health policy impact, the role of the medical profession in such a process, what has been the experience of Oregon and other countries that have adopted different forms of aid in dying? What are the effectiveness of the procedural protections that I just summarized for you? One shouldn't talk about this without being transparent about their own views of it. I think the current states that have adopted it have adopted a reasonable enough compromise between autonomy and protection. But my concerns, as I'll go in a little bit later, are more along the lines of I'm not sure those protections will be able to last for very long. On the personal side, the power of personal stories is huge here. This issue never got as much attention as it did when the plight of Brittany Maynard hit the news in 2014. She was a young woman who suffered from a brain tumor that was going to cause a great deal of suffering and loss of control. And she became an advocate for the legalization of medical aid in dying. Her situation was followed in the news all the way up until the time she ended her life through using aid in dying. So those kinds of stories are very powerful, but individual stories are not a good basis to make public policy with alone, but they do have a huge impact. Some have raised the question of whether the lack of acceptable alternatives can affect voluntariness. We don't have a level playing field in this country on access to health care. And does that skew people's thinking about this? Dr. Thomas Matamore, in an article with other co-authors, found that of over 3,000 seriously ill hospitalized patients in 5 academic medical centers, 30% said they would rather die than live permanently in a nursing home. And that's a view that you commonly get. In some cases, it's a justified view. In other cases, in most cases, it's not. But that's a view that many people hold. And would that bother you if one of those persons, rather than living in a nursing home, would rather opt for aid in dying because we haven't given them quality of life choices that they want? Disability advocates are split on this issue, but many are quite vocal on it. The group Not Dead Yet, in particular, a Chicago-based group, is very vocal on it. This was an excerpt of testimony just 2 weeks ago before the New York State Assembly Health Committee, the testimony of which is considering a bill to legalize aid in dying. This was testimony of Catherine Carroll from the Center for Disability Rights. And she said, just a short excerpt, proponents claim that this bill is not targeting them, i.e. persons with disability, but only makes assisted suicide available to the terminally ill. While not every person with a disability is terminally ill, every person who is terminally ill is or will eventually become a person with a disability. The suggestion that disability acquired as a result of illness is cause enough to end one's life is a devaluation of disabled people's lives and is offensive. The way to address these issues is not to offer a way out, but to provide adequate supports and services. So that's a very strong view of some disability advocates. Other disability advocates have been supportive of having that option should they want it. Now, can cultural norms change? Can they loosen? This was an article from the New York Times a year or so ago. The Dutch law, which allows assisted suicide, is considering the Dutch are considering a proposal to legalize assisted suicide for older people who are generally healthy, but they have led a full life and want to end it. That has stirred up a big debate in that country. But the fact that they're even having the debate shows that cultural norms can be challenged and sometimes change. The Oregon experience. Oregon has had an annual report each year since their program began, and they have data from really 1998 to the present. And since 1998, the top line shows the total number of persons each year who have opted for aid in dying. In the most current year, 2017, 218 people opted for aid in dying, 140 who actually carried through with it. Excuse me, I'm saying that in reverse. 218 requested the option, but only 143 carried through with it by the end of the reporting period. Now, Oregon has about 35,000, a little over 35,000 deaths per year, so that's a small percentage, but it has slowly increased over that period of time, but it still remains small. And looking at the people who opted for it in Oregon, I'll quickly summarize this. Little over half are male, and most are older, over age 65, the median age 72. Most are white, most are fairly well educated, most had cancer, Most were enrolled in a hospice program. They all had insurance of some sort, private, Medicare or Medicaid or other governmental program. A little over 5% were referred for psychiatric evaluation beforehand. So it's funny, I mean, what do you think about those statistics? It seems to be that a relatively white middle or upper middle class group is opting for it. Of course, the population of Oregon is skewed heavily towards that. But does that make you feel safer, or does that bother you that it isn't more diverse? It's hard to evaluate that evidence. Now, let me turn to the last thing I want to touch was some of the legal issues that I think are going to evolve down the road on assisted suicide. We know from our common law legacy and from constitutional decisions of the Supreme Court that our law, our Constitution recognizes the right to refuse unwanted treatment, and it's based upon a liberty interest. This was the famous case of Nancy Cruzan versus state of Missouri that was decided in 1990. We also know that the Supreme Court looked at the right, quote, right to aid in dying, absent a statute, and found that there is no such constitutional right. The alleged right to control the timing and circumstances of one's death was not in the Constitution as far as the Supreme Court was concerned. But they said that states certainly had the option of giving people that right. So the result is we have a constitutional right to say no to treatment. And in dicta in the Cruzan case, there's also, there may be a right to not be in pain, which would be good. It was somewhat alluded to. But we don't have a right to affirmative assistance by others. We don't have a constitutional right unless a state decides to give you that right. And a handful of states have done exactly that. Will the limits on Death with Dignity Acts hold? That's what the Oregon Act is called, the Death with Dignity Act. Just last month, the chairman of the Oregon's Legislative Healthcare Committee, Representative Mitch Greenlick, said he plans to introduce a bill that in the next legislative session that would change the timeline from 6 months to 12 months. So are we beginning to see some suggestion of erosion? Consider two scenarios that I want to pose to you and what I think what are realistic likelihoods for litigation in the future. I don't know if it's how distant in the future it is, but here's one scenario. John is a paraplegic and now diagnosed with terminal cancer. He cannot self-administer the medication. He wants aid in dying. He's competent, he knows what he wants. He's now diagnosed with a terminal condition. He can't get it under the Oregon law or the other states' laws simply because he can't self-administer the medication. And maybe it's not paraplegia, it could be ALS, any other neurological condition that prevents him from self-administering. How would, if the law were challenged, if he challenged the law saying that it discriminates against him, how would courts treat that? Well, if the state decides to grant, as Oregon and other states have done, functionally able individuals with terminal disease the right to aid in dying, then denying it to a person with a functional disability does raise an equal protection concern and concerns over discrimination on the basis of disability. So how would a court take a look at that if it were challenged? Well, courts, at least in looking at most legislation, have imposed a rather low bar in which if the law is rationally related to a legitimate state interest, a social or economic interest, then fine, the court's not going to overturn it. However, they use more than that test. If the discrimination involves a suspect class, which would be things like race and gender, then the court imposes a very high test. It says the state must, the discrimination must be narrowly tailored to serve a compelling state interest. And then on a few occasions, it's used a kind of a middle test applied to what they sometimes have called a quasi-suspect class, which we don't quite know what they mean by that. but then they say the test is that the discrimination must be substantially related to legitimate state interest. So how would they approach this case of John challenging that statute? Well, there's only one case that really is cited as the precedent here, and it was a case in the Supreme Court way back 30 years ago in which a group home or a planned group home for the mentally retarded, as the term was used at that time, was subject to a fairly onerous special use permit process they would have to go through. But other group homes were not. So they challenged the law as unlawfully discriminating against persons with disability. The court said that they would assess this under the low standard because this was not a suspect class or a quasi-suspect class, which is somewhat of a surprising finding, but that's what they said. But what they did was that they found that the law requiring a special use permit violated the Equal Protection Clause anyway, reasoning that there was no rational basis in the record for believing that the group home would pose any special threat to the city's legitimate interests. Rather, it was an expression of irrational prejudice against the mentally retarded. So they said we're going to apply the low standard, which almost never results in the law being overturned, but they overturned it anyway. So they really treated this group as at least a quasi-suspect class. So the lesson from that I think is that we follow what the Supreme Court does rather than what they say. And in that case, what would happen if the law were challenged by John, who's the paraplegic with terminal condition? I won't try to predict, but I would say that he has at least a credible argument for challenging the law and having that right. And finally, another scenario. Now that let's say John has won. Now Anne sues because Anne has been diagnosed with Alzheimer's disease and feels strongly that she would not want to continue living when she was no longer able to recognize or communicate with loved ones. So she spells out in her advance directive exactly that she wants to be euthanized when she reaches that particular point, and she names an agent to act on her behalf. So now she challenges the Oregon model. Well, what does the law say? Well, we now have a well-articulated principle that an incompetent person should possess the same legal rights as is possessed by a competent person. And in the Nancy Cruzan case, that was the right to liberty to make choices. But the constitutional principle says you don't have the right to aid in dying. However, the state has given you the right to aid in dying to some people, but not to others. The Supreme Court has also recognized that such a right must be exercised for her, if at all, by some sort of surrogate. And when they looked at the Nancy Cruzan case, they were assessing whether or not the state could require clear and convincing evidence of Nancy Cruzan's actual wishes about that particular treatment. And the court said that, well, that's a procedural safeguard that we think is not an undue burden on the liberty interest, and it has a protective rationale, and so we're okay with that in her case. But we do have this principle that you don't lose your legal rights just because you lose capacity, and there is a recognition of surrogates acting for you. And again, the same kind of equal protection argument would be brought, and whether Anne would win that case, I won't try to predict, but I will say that she has a credible argument that would be worthy of the litigation. But that probably won't happen until enough states adopt aid in dying to make it feel more normalized. Then people get bolder about the kind of litigation that they want to bring. And that's just the way law evolves in this country. So where we may land, if those scenarios played out, we would land with adults with a terminal illness, 6 or 12 months, depending upon where the legislatures go, entitled to choose or receive and self-administer a lethal prescription, or choose, receive, and have the prescription administered by someone else if they're unable to self-administer. And in Anne's case, it would mean adults lacking decisional capacity who clearly have spelled out in an advance directive their wishes to have their life ended at a specified time would have the right to do that, because discriminating against them would be unlawful. So if that's where people feel comfortable ending up, then fine, go that direction. But it gives a lot of us a lot of pause and discomfort, and we're still working it out. So what's the best strategy? Well, I think it's to create as many options for dignified, quality, supportive care, aid in living, as I've called it, as we can, to multiply them, to make them accessible to people. And we're probably going to have, at least in many states, that right to aid in dying, but it should be an option that has a very low-level demand because we have a very good system that provides aid in living. So that's where my focus is going to be the next years of my life, and I hope you all too. Thank you.
I think we have time for one question.
That question. Thank you for giving us such mindful education. My question is, do you think that if we, as a society, we implement driver's licenses, we have to read a book, we have to take a written test, we have to take a road test, if we implement this type of information about right to live and right to die, and have that in high school, would that be something that the children might be able to go home and talk to their parents about so that it's a well-informed child bringing it up? Because lots of people are attending schools, so the education would be privy to them, and it could get to the seniors or the people who are aging and not get lost in the sauce.
Well, at least some aspects of this I think are appropriate for a high school level, particularly teaching people about the options to name a surrogate and why that's important, even as a young person, and what that conversation should involve. For someone graduating from high school, telling them today what the world is going to look like in even another 10 years is hard to do because it's changing so fast. But certainly on advanced care planning, there have been recommendations that actually be something at least taught on a beginning basis in high school. Why not encourage people at graduation to name a proxy right at that time? Thank you.